assessing AI-ECG performance and specifically trying to assess the literature as a non-expert in data science classification metrics, which can be very challenging for someone who is not an expert in the field. So there are novel, even revolutionary insights that have been presented in the literature for ECG interpretation, and there is huge potential impact from that. And performance, or what is understood as huge potential impact, is reported in terms of the performance improvement. And that can be reported in intimidating looking tables like this one, containing many, many numbers, and each number may correspond to a different performance dimension. So it can be very, very challenging for a non-expert to parse all these numbers and all this information. Usually what is reported for performance of the model, for classification performance, meaning how well does the model perform against the ground truth as it exists associated with its record. And there are many, many data science metrics that characterize multiple dimensions of that. You see them here. I know, arguably, there are too many of them, and not all of them are equally useful or practical. The area under the rho curve is arguably not very practical and not very illuminating sometimes. It can be very useful for the developers, but not necessarily for the practitioners, for the clinician users. Especially as interpreting these metrics requires an understanding of the prevalence of the target on the population and the makeup of the population on which these models are developed. And this can be very challenging for people to understand, and trying to understand what these metrics mean for the fitness of the model for clinical practice. So, as I said before, my advice, if it's too difficult to understand the complexity of all these numbers, my shorthand for assessing the literature is try to assess the sensitivity and positive predictive value of a model for your population of interest or for your practice. Sensitivity is, out of all the true positive cases that go through the model, how many of them does the model detect? And positive predictive value is, out of all the times that the model gives a positive prediction, how often is the model correct? And positive predictive value especially is a very practical metric and often underappreciated or undervalued in the literature. So these metrics together is a very good combination because it highlights that there's real tension between performance dimensions. If you try to increase sensitivity, you will reduce the positive predictive value of a model, and vice versa. So there are real trade-offs in performance dimensions that need to be considered for how best to deploy the model in clinical practice. And thinking about that optimal balance shows how mature a model is in thinking about deployment in actual practice. And also, the last part of the assessment, thinking about extrapolating these numbers for your population or your practice, can actually be very hard to extrapolate, or even impossible sometimes for some of the literature. So that highlights also a real distance that exists sometimes between literature and clinical practice. So here is an example from the literature. Hypertrophic cardiomyopathy is a great example to talk about this because it has very low prevalence, 0.2 to 0.5% in the general population. And again, prevalence can be a very confounding factor in interpreting these numbers. There is huge value in hypertrophic cardiomyopathy detection with a huge potential for positive impact in these patients' lives. And it is a very, very common endpoint, very common application in the AI-ECG literature. So this is work by, two of the best groups in the world shown here. So trying to assess the numbers that you might see in the literature, area under the curve, you might see here 95 to 97%. Again, I told you before, interpreting AUC can be challenging, but these are definitely very high numbers, and they definitely show very, very promising performance. Trying to assess the sensitivity is around 90%. That's a very high number. 90% of patients with HCM captured when many of these ECGs are not reviewed by a clinician with a cardiomyopathy mindset, right? And the positive predictive value shown here is 30%, which seems very, very manageable in practice. But again, prevalence is a very confounding factor. And in fact, that research is very often done, this is very common for HCM especially, on an enriched population, a population with enriched prevalence, usually something around 5% for HCM development. That's at least an order of magnitude higher than the true prevalence. And very often you cannot find the positive predictive value that would apply for a general population with some math and simple assumptions that is less than 5%. Or 1% for this publication that has done the calculation directly. So a positive predictive value of less than 5% would have very real, painful trade-offs for a healthcare system to support. So that is probably not realistic for a real-world screening application. It doesn't mean that this is bad literature. This is some of the best literature in the world, and it's extremely valuable to have that. But it shows that these studies are still proof of principle, and there is some work to be done yet about thinking about grappling all the dimensions about bringing these models to clinical practice and finding appropriate performance balance to do that successfully. So a low positive predictive value means an unrealistically high number of false positive detections. 5% positive predictive value means 20 false positives for any true detection. So benefits from a true detection, again, these benefits can be huge for HCM, but they need to be balanced against the burden of these false positives alarms, whether that's increased burden on the echo labs to deal with all these procedures, waste of healthcare resources, even patient harm can result from these false positives. Leading groups have made great advancements towards a more realistic model formulation, some of the groups that you saw in the previous slide, as well as experts that you will hear in these learning labs. So controlling these painful trade-offs is very necessary for the successful clinical integration of AI-ECG. And the least well thought out that appropriate balance is, the more painful trade-offs these models would have when brought to practice. So thinking about that optimal balance, as well as other performance characteristics, can be site and application dependent because, again, it depends on the benefit of the true detections, which, again, can be huge for something like HCM. And it can be site dependent because it depends not only on the potential burden on the echo labs, but also in the institutional investment in the AI-ECG and the potential new workflows around it. I also wanted to hold some space for some data science pathologies in quotations, that come up if you believe in the data too much. And as a data scientist, I should know about it. It is possible to believe in your data too much, and the data-driven development can deviate from what application of these models in the real world would look like. So, for example, the fundamental assumption that there's a binary 0 or 1, true or false, ground truth associated with its record, it's kind of a simplification, and it strips away ambiguity that exists in reality. There can be data correlations or assumptions that don't generalize, especially if you only develop and validate in a single source. Now, it's pretty straightforward to control that with external validation, but there are many forms of selection bias, sampling bias by selection of population, that even on external validation would not be controlled. And that might include selecting an enriched population with elevated prevalence, or even selecting a population that has a confirming echo procedure that might be different from a general population, or selecting much cleaner data than would be encountered in practice. And that could mean removing noise or artifact, or even removing confounders. Dr. Ang mentioned the application of separating left bundle branch block from right bundle branch block. The performance you will get on left bundle branch block or right branch block for this application will be much higher than you would get in real practice when you have a much larger spectrum of potential endpoints. So all these built-in simplifications may not be captured by the evaluation metrics that we showed before. So as we are looking at these performance evaluation metrics, we should understand that they could be limited. All of these can be mitigated if understood. And the best groups in the world are doing that. It could be problematic if unaccounted for, and that is exactly the impact that would have to real-world practice. So the intelligence can be artificial, but the problem solved has to be a real one. If it isn't, it will have painful trade-offs when brought to real practice. So a lot of the AI-ECG capabilities that have been demonstrated in the literature, we should understand when they are, at the very least, proof of principle. It is still extremely valuable and necessary literature and a necessary step to bringing them to practice. And they have indeed demonstrated the potential for revolutionizing the insights that we can infer from the ECG. The next frontier is learning from the real-world application of these tools. And some of the leaders in the world, including speakers in this learning lab, are doing that today. There have been great strides in prospective RCTs or deployment in trial sites that demonstrate real-world impact. So the ultimate assessment is the full evaluation from the real-world application, and that includes assessing these performance metrics on the true evaluation in the real world, but also assessing all impacts beyond these standard performance metrics. And in this context, we can think of explainability, usability, trustworthiness, robustness, scalability as almost like separate metrics that we should not forget about. And of course, the impact that they would have on clinicians, patients, and how easy, ultimately that determines how easy and successful these tools can be in integrating in existing workflows or developing entirely new workflows around them. Thank you very much.